Hello everyone and welcome to our first webinar on leadership and supervision in large-scale vaccination programmes. I'll first introduce myself and then I'll let Helen introduce herself. My name's Heather Randall. I'm professional lead for primary care at the Royal College of Nursing.
And hello, I'm Helen Donovan. I am the professional lead for public health nursing and have been leading some of the work around the COVID vaccination programme for the RCN.
Just a few things before we start I thought I'd go through with you. Just to say that there's going to be we've had over 500 people who registered for this webinar, so thank you all of you for your enthusiasm and wanting to take part in this. There is a chat function and you can put your questions into the chat, and we will do our best at the end to answer a couple of them as they're published, and that the webinar is going to be recorded, so it'll be available within the next week, and you'll all get notifications so that you can watch it all again in case you've missed anything or in case you want to direct other people to it as well, so you'll have the opportunity to do that. We're going to do our best at the end to answer a few of your questions, but anything that we don't get a chance to answer, if it's sort of a theme that we feel we need to sort of respond to, then we'll probably put it in our FAQs. So we've got FAQs on our website, and I hope that you guys have all had a good look around the website, the RCN website on immunisations, because this presentation is on it, and there's also lots of other resources that I know you'll all find really useful. Okay, so without further ado, let's progress. So we're going to talk through the leadership and supervision for delivery of large-scale vaccination. I'll start, and then Helen will go through the second half of the slides, and there'll be an opportunity to ask questions at the end. So this is just kind of a breakdown of what is in the presentation. We're going to do learning outcomes, we'll talk about the RCN position on COVID vaccination, our overarching principles, training requirements, accountability and delegation, which I know is a topic that everyone's interested in. Then we're going to talk about legal principles, things like consent, duty of care, accountability, and then we'll talk about medicine administration, so talking through things like prescription only medicines, patient group directions, the national protocol as well, we'll go through that, and then some guidance on how to keep up to date as well. Next slide, please. So the learning outcomes from today. So we're going to outline the agreed training requirements for staff in a large-scale vaccination programme, analyse roles and responsibilities, so we'll go into more detail about that. I've said before we're going to talk about accountability and delegation, and we've got sort of a chart that we can show you about that. The legislative framework for safe vaccinations, and then we're going to talk about patient group directions, national protocols, that kind of thing. And then talking about local planning as well, and I'm hoping that we'll be able to bring in some of our own experiences, because both myself and Helen have been out vaccinating in our areas and seen some really good practice, which we want to commend you guys for all the hard work that you've been doing. And we'll talk about the training as well, so we'll just direct you to the training and where to get it from. Okay, next slide please. So our position as the RCN is that we want to be able to support the safe delivery of the COVID-19 vaccination programme. So our key areas for us are patient safety, public interest, and also we want to make sure that with the delivery of the programme, our responsibility is to support the delivery of the programmes and the vaccines that have been approved through the MHRA. I've put a link there to the Green Book on immunisation, so that is the place that you go to for all of your information, really. It's a very good resource, and it has been updated for the COVID-19. I think it's chapter 19A from what I remember, but have a look at that.
14A.
14A, thank you, there you go. Our job as well is to support the nursing voice and to celebrate the fundamental role of nurses. So nurses are working hard in these teams to deliver vaccines safely and effectively to people. Also expanding the work. So the RCN supports expanding the workforce as well, but we our key for that is that the people that are vaccinating are trained and well supervised, so they have the support that they need to be safe vaccinators in this new programme. We also want the RCN would expect organisations to make sure that vaccine is readily available. So I've heard some really good stories in my area of staff being vaccinated and the vaccine being made readily accessible to them, and the RCN would recognise that as good practice. So hopefully that's what you're seeing in your areas as well. Next slide, please. So the RCN position on getting the vaccination. We always support every year the flu programme, so we would encourage our members to have the flu every year, the influenza vaccination, and it's the same with the COVID-19 vaccination. We feel it's really important for staff to protect themselves and their families and their patients, and obviously the wider community as well, by having the vaccination. That said, though, we wouldn't recommend that it's mandated. We don't think it should be a mandatory requirement to have the vaccination. And also, but we would we expect organisations to be proactive in their approach to making vaccine easily accessible to staff and encouraging them to have it, but not coercing them or forcing them to be vaccinated. That definitely wouldn't be something we would support. Next slide, please. So some overriding principles: maintaining patient safety and public interest in vaccination. So we feel that anyone who's vaccinated should be trained, informed and be supported as part of the workforce. They should also be offered supervision and rest periods, because we're aware that there's a lot of staff out there who are working additional hours in excess of the hours that they've worked previously in order to meet the demand and to step up and do this vaccination programme. And we commend you all for that, but also recognising that you do need opportunity to take rest as well. We think that we want the vaccines to be stored safely and transported safely, so there should be a robust process for that to happen. Another overriding principle is that vaccine preparation should be against a standard operating procedure within your area. And we've given you a link there, so there's a link to Specialist Pharmacy Services advice on standard operating procedures, so you can have a look at them. Also, staff should have access to appropriate PPE at all times, and they should be following the national guidance on PPE when they're vaccinating and generally, and that members of the public and healthcare professionals should be encouraged, if they feel that they've had a side effect from the vaccination, a severe side effect, that they should be reporting that on the yellow card system. And it's important to recognise that both the public and healthcare professionals can do that. So we've provided you with a link there to have so that you can do that as well. Next slide, please. So this is just an update on the vaccines that are currently available and have been approved by the Medicines, Health and Healthcare Products Regulatory Agency, or the MHRA for short. So at the beginning of December, the Pfizer-BioNTech vaccination was approved by the MHRA, and this is a messenger ribonucleic acid vaccination, so a messenger RNA vaccination, and it contains the genetic sequence of the antigens found on the surface of the SARS virus. So that was approved on the 2nd of December. On the 30th of December, the vaccination was approved, the Oxford vaccination, so the AstraZeneca Oxford vaccination was approved just between Christmas and New Year. And that is a non-replicating viral vector vaccine, and it uses a weakened adenovirus as a carrier to deliver the genetic sequence for the SARS virus into the body. So different to the other one. And then we've just, on the 8th of January, the Moderna vaccine was approved. Unfortunately, this one is not going to be ready until the spring, but it's under the same principle as the Pfizer vaccine. It's a messenger RNA vaccination, exactly the same, but it'll be ready later on. Okay, next slide, please. This is a list of the vaccines that are in development or still in trial phases. We've talked about a couple of them. So we've talked about the Pfizer-BioNTech one and the Oxford AstraZeneca and the Moderna. But as you can see, there's a few others, and these are the amounts that have been ordered by our government to be used in this country to vaccinate people. So once the others are approved, some of them are still in early trials, phase 1 and 2 trials. As you can see, we've got a Novavax one that's in phase 3 trials, and the Janssen one, which is also in phase 3 trials. So we might see them approved in the not too distant future. But at the minute, we've got 2 that we can get in supply and 1 that we will get from the spring. Next slide, please. So this is some information. I've mentioned the Green Book, some guidance and clinical overview of the vaccines, guidance on health for healthcare professionals. There's a link to that as well, and some other resources and e-learning resources. So the initial aim of this vaccine programme is to prevent severe disease in the most vulnerable, and that's why the JCVI have recommended groups, a process, sort of a series of people who need to be vaccinated, starting with our most vulnerable and sort of working down. And at the moment, we're working between cohorts 1 to 4. So that's up to 70 years and above is being vaccinated. And then there's further guidance as we move down the cohorts, and then the JCVI then will rethink their strategy after that. With the vaccine, the long-term efficacy is not yet available, so we don't know how long it's going to provide protection, and also we don't know the impact of transmission. So once you've been vaccinated, we don't know if it reduces the transmission of the infection, and this is all information that will become available as more and more people are vaccinated and as more data is collected. Just a note to everyone that the JCVI recommends that you shouldn't have another vaccine within 7 days of the COVID vaccination. So I know when I was vaccinating, I checked that no one had had a vaccine within the last 7 days. There is sort of some tolerance in that, but the general guidance is that they shouldn't have had another vaccine within 7 days. So adverse events are likely, and we are all used to explaining an adverse event. So local reactions like pain and tenderness at the injection site, headaches, fatigue, sometimes at a high temperature. These are all normal adverse events, and it's good to be sharing that information with our patients when they're vaccinated, so they're aware that this is normal. All patients should be given post-vaccination advice, and also either an appointment for their second dose of vaccine or a date when the vaccine is due, so when their second dose should be given. Ideally, we would be giving them an appointment, but that isn't always possible, and we acknowledge that. So once someone's been vaccinated, they should be observed, as with any vaccination, for immediate reactions. The MHRA have stipulated that the Pfizer vaccination needs to have a 15-minute monitoring period after vaccination, just in case there's any reactions. And obviously there's always a chance that if someone's had a vaccine, they might feel faint or might actually faint. So with any vaccination, we'd always recommend that people don't drive for at least 15 minutes after they've had their vaccination. I saw a patient who felt a little bit unwell after she'd had a vaccination and started to faint, and it was mainly because she hadn't eaten or drank all day when she came in to have the vaccination. But still, we need to keep an eye on that. Next slide, please. So I'm just going to talk a little bit now about the training requirements, and this is always dependent on the registration status of the person and their experience. Next slide, please. So looking at the workforce, there's lots of different sites now for vaccinations, and we've all seen them across the media, haven't we? We've got hospital sites, community sites in primary care. Primary care networks have been setting up sites across the country. We've also got large-scale vaccination sites, and some roving teams now who are visiting housebound and residential settings. And these are gradually, we've seen them grow, haven't we? And the response has been absolutely amazing over the last few weeks and months. And you can see by the amount of people that have been vaccinated how successful that's been. There's lots of different roles within a vaccination programme. And, you know, just to note that it is a teamwork and it is really important. So there's non-clinical roles, so administration and stewards. You know, your stewards are key to something, making sure that the flow of patients goes in the right direction, that people maintain their safe distances. All of these things are absolutely invaluable and key to a programme. There should be, there's clinical managers as well. And there's registered healthcare professionals, and we've got two different types. There's some that are experts, some who've vaccinated for years, and experienced vaccinators, and then healthcare professionals who are untrained in immunisation or haven't vaccinated for a little while. And then there's our unregistered workforce as well. So staff who are supporting the vaccination programme in various different ways, and we've seen that being used across the country. Next slide, please. So training requirements are always dependent on your level of experience, but as a general, you should be able to demonstrate all of these if you're going to be working in a vaccination area. So general principles, immunisation and vaccination, and legal issues. I'll refer you to the National Immunisation, or what's it called, Helen? The National Minimum Standards for Immunisation. That's right, I've remembered it now. They're also the understanding of medicines authorization, which Helen's going to talk to you about in a little while. So national protocols, and there are a couple of national protocols out now, patient group directions, patient specific directions. So an understanding of them is important with training. Anaphylaxis and basic life support, specific information around the COVID vaccination programme, and also an overview of the vaccination programme. Statutory and mandatory training should be up to date as well, and on-site organisation training, so understanding the flow and walking through the site that you're going to be working in, so you understand who everybody is and where everything is, that kind of thing. And then a competency assessment for those that need to be assessed in doing the vaccinations. And just a little note that nursing associates are England specific, but at the moment they cannot work from a PGD, nor can physicians associates. Okay, next page, please. So assessment of competence. So there's no exact process, there's no exact way to assess someone. Obviously we need to be guided by the National Minimum Standards for Immunisation, which are readily available, and I'm sure there's a link to it in part of this presentation. Immunisers need opportunities to observe and discuss any issues with an experienced practitioner or supervisor. And when we talk about an experienced supervisor, it's someone, they don't necessarily need formal teaching qualification, they just need to be experienced and competent as an immuniser, so that they've got the confidence then to train a new immuniser and to support them. So all immunisers should have, they need to be able to demonstrate appropriate standards of practice, and they should also have an opportunity to have supervised practice, and this needs to be in a structured way, all being that it might be in a quick process, and there's no guidance to say that how many times it needs to be, how much supervision someone needs. You know, one person might get it first time that they're supervised, other people might need a little bit of support, and that's something that the supervisor and the immuniser need to agree between them, and the supervisor needs to be assured that the person who's doing the immunisation is competent, and then provide ongoing supervision and support. Okay, next slide, please. So we're just going to talk a little bit now about accountability and delegation. Next slide, please. So this is a summary. This is talking about the national protocol, and this is a summary of functions necessary for vaccination to be delegated under the protocol. So under the protocol, the delegation comes from the Secretary of State. Please nod, Helen, if I'm saying that properly. Yeah. Right, so from the Secretary of State for each of the stages. So just talking you through them. There should be someone who is has responsibility for that vaccination program. So a clinical supervisor or manager, and that might be a shift supervisor, someone who's in charge for that session. And their responsibility is to oversee the process, ensuring stock levels, safety, the cold chain is maintained, and that there's an adequate staffing and a good skill mix within that program. They're also responsible for ensuring that staff have the training, education and support and have been assessed as competent. And that needs to be a registered healthcare professional, so a doctor or a nurse or an allied healthcare professional who has that experience. And then depending on the model that you use, there will be people either working in more than one of the roles underneath, or they might be doing all of the processes or an individual part of it. So there's lots of different steps that they can do. So we can have, so registered healthcare professionals can carry out the clinical assessment, and that involves, you know, talking to the patient, gaining their consent, ensuring that it's safe for them to be immunised, talking about contraindications, any allergies, all that kind of thing. So that's clinical assessment needs to be a registered healthcare professional. And then when we're drawing up and reconstituting the vaccine, that as a principle should be done by a registered healthcare professional, with a caveat that some unregistered practitioners can do it. And for example, that would be someone like a pharmacy technician who works in that kind of environment and regularly mixes vaccines or mixes medicines in that way. And if you have someone who's working an unregistered practitioner, they would need to be supervised when they're doing that process. Then the vaccination, administering the vaccination, again, like I say, this could be the person doing the clinical assessment could also be vaccinating. They could also be drawing up or reconstituting and drawing up the vaccine, but also the stages might be broken down. So the vaccine administrator, this can be a registered healthcare professional or an unregistered healthcare professional with the appropriate training and competence and regular supervision of that person. And then unregistered practitioners, again, all registered practitioners can be doing the administration. So doing the record keeping and transferring the records across. So completing that process. Next slide, please. So just going to talk about some legal principles around consent, duty of care, accountability. So next slide, please. So consent. Now this is something that I'm sure most of you are used to gaining, and just a reminder that consent is a process and is not a one-off event. So as part of an immunisation programme, although someone might be gaining consent as they fill the form in, if you're the person giving the vaccination, you're still going to check that that person is happy to have the vaccine and gain their consent as well. So some key principles. Does the individual know what they are consenting to, the vaccination that they're having? Do they understand the possible side effects of that vaccine? Have you advised them where the vaccine's going to be given? And that can be a bit of a challenge in this cold weather. Lots of different layers. I know I helped undress quite a few people the other day. So have you advised them where it's going to be given? Have you explained how they're going to feel afterward, what some of the side effects are, the common side effects, which you've already talked about? Talk about what to do if they feel unwell. You know, they can take paracetamol, but how long to expect to feel unwell and what to do if that doesn't improve, and when to seek further advice. Giving them an information leaflet, I tend to direct them to some of the key information inside that leaflet because they very often handed it back to me. So try and make sure that they've had a look at that and they've had some information. And then also a bit of advice on, you know, I'd say this is good bedtime reading, but please remember to have a read of it. And then regaining consent, are they happy to be given the vaccine? There is no legal need for written consent. Verbal consent is adequate, but also to be making sure that you document that when you're doing the vaccination. Next slide, please. So who can give consent? Who is competent to give consent? So you must always gain consent. I think we've talked about that. People that can gain consent is anyone who's over 18 who has capacity, and we would always assume someone has capacity unless otherwise proven. People who are between the ages of 16 and 17, they're entitled to give their own consent, and children who are younger than that can give consent through GILIC competence, as long as they're deemed GILIC competent, and I'm sure that you guys understand that. In order to give consent, that has to be informed consent, so the patient has to understand all the things that I just talked about and understand what they are consenting to before you vaccinate them. With some patients, it may not be appropriate to be vaccinating them in large-scale vaccination centres. I know people with language difficulties, for example, or people with learning difficulties, or some people who find a large-scale environment like that overwhelming actually might not be able to give consent. And it might be that we think of other areas to take them to. It might be more appropriate to vaccinate them in their own home or in a smaller clinic as they become more accessible. Next slide, please. Okay, so as I've said to you before, this is based on the Mental Capacity Act, and we should always assume that someone has capacity to make a decision unless it's proved otherwise that they don't. When gaining consent, you support people to make a decision for themselves, and this might be a process. As I said, you might need to use some communication tools in order to ensure that they understand and make sure that they know what you're asking them to do. And there might be some people where time of day is relevant, so some people might be better at giving consent at certain times of the day rather than other times of the day. And capacity can fluctuate. I'm sure you understand all of this. And like I say, it might fluctuate during the day, but it is really important that we gain consent at the point where we're vaccinating that person as well. And we must as well remember to respect unwise decisions. As long as someone understands what they're doing and understands that they're making an unwise decision, then that is their right, as long as they have capacity. So don't assume that just because they made an unwise decision that they don't have capacity. Where a decision is made for someone who doesn't have capacity, it has to be in their best interests. And one of the key things to look at is kind of historical data. Have they always had their flu vaccination, for example? Did they consent to that previously? So if they did have capacity, would they probably give consent? Any treatment and care provided to someone who lacks capacity should be the least restrictive possible, so that we don't take away their basic human rights and freedoms. And this might be best served in a familiar setting. So like I said, maybe in a GP practice or in the care home that they're in, so that they can understand it. This is the last slide for me. Next slide, please. So just talking briefly about best interest decisions, and as healthcare professionals, it's our role sometimes to make a best interest decision for a patient. So if a patient lacks capacity or has fluctuating capacity, as I said before, if the professional can't accept consent at that time, so isn't able to gain consent, then they need to make a decision, and they can either do that if someone in the family or a relative has a health lasting power of attorney. It's really important that it's a health lasting power of attorney, because often people have lasting power of attorney but it isn't health related. Then they can give consent for that person. Check to see if there's an advance directive. Very often though, unlikely to cover vaccinations. And then, like I said to you, consider the best interest decisions, looking at historical data, talking to family members, but just remember that family members cannot give consent to a relative's treatment. I think that's it from me. Next slide, please. Over to you, Helen.
Okay, so thank you, Heather. So just quickly going to touch on vaccine storage. And obviously there's been a lot written in the press, particularly about these vaccines and the cold chain. But actually, this is not new for vaccines. We call this the cold chain. So that's the process from manufacturer to delivery. And it's really important, obviously, that vaccines are kept in that cold chain. So for most vaccines, we keep them in the refrigerator, and that's between 2 and 8 degrees. And as you know, with the Pfizer vaccine, there are requirements that it needs to be frozen before it's brought out of that deep freeze. So, and obviously that's a process that's usually managed outside of the vaccine centre and then delivered to the vaccine centre, or in the hub where the vaccines are given, and then kept in the refrigerator between 2 and 8 degrees. And obviously you need to follow the guidance and look at the e-learning resources, because it does go through all of that information. Can I have the next slide, please? So as Heather touched on, we often get asked as a college, so who can give a vaccine? What are the legalities? And the underlying principle is that if you deliver care to somebody, that means that you are accepting that responsibility, and that doesn't matter whether you're a registered healthcare professional or an unregistered healthcare professional. It's about having the skills and competence to do that. Now, obviously, there are local requirements and sometimes country requirements that you need to be aware of, but in pure legal terms, it's when you're thinking about who can do something, it's what standard of care would be expected. So from the purpose of this presentation, when we're talking about the accountability and delegation, there's a couple of things to think about. So when you're delegating staff, or when you're deciding that this is something that you're going to take on, you need to consider, first of all, medicines legislation, and also the whole issue around accountability and delegation. So I'm going to go through those. Can I have the next slide, please? So in terms of accountability and delegation, now this doesn't matter whether you are a registered healthcare professional or an unregistered healthcare professional. You have a responsibility in civil law, and that's with your employer. So you've got a contracted employer, you've got a job description, you've often got a name badge that says that you are who you are and what your job is. You've got a responsibility to the patient to respect their wishes, to get their consent, and all of the things that Heather was talking about. Obviously to yourself, to be appropriately trained and experienced and be able to follow best practice, and to society in general. And as registered healthcare professionals, if you're on the NMC register, you also have additional accountability to the regulator, and for nurses, obviously that is the Nursing and Midwifery Council. So what we've sort of considered as a college is, when you're accepting responsibility or when you're deciding to delegate, think of these 3 A's. Have you, or has the person you're delegating to, got the ability? Can they perform the task? Is that something that they can do? Have they got the basic skills? Accountability, you've accepted the responsibility and agreed to undertake this role as part of your job description, and that you are giving authority that somebody can perform the task working within the policies, procedures, protocols, and that includes having the authority to administer a medicine. And I'm going to come on to that in a little bit, because prescription-only medicines need their own authority as well. Can I have the next slide, please? So in terms of ability, Heather mentioned before, we have in vaccination the national minimum standards for immunisation. There are 2 sets of standards. There is one for registered healthcare practitioners, and that was updated in 2018, and the RCN were part of that working group, and for non-registered healthcare practitioners, and that applies in England and Wales. And Scotland have their own version of that. In Northern Ireland, the non-registered healthcare practitioners don't vaccinate. But there are clear sets of standards which aim to make sure that there's a high level of knowledge and a positive attitude to immunisation, so that healthcare workers are doing all of those fundamental principles of delivering safe care and maintaining trust with the public and maintaining a high vaccine uptake, so that they can talk to people with confidence. So those are the national minimum standards. Can I have the next slide, please? So knowledge and skills, two different things. You can have the knowledge, but then how can you acquire the skills? And there's been a lot of discussion, obviously, in the development of this programme, is how do we make sure that people have both? So whilst there are the national minimum standards, it's quite recognised that not everybody involved in the COVID vaccine programme or even the influenza vaccine programme will need all of those skills. So there are some separate competencies specifically for COVID vaccinators or for influenza vaccinators. So you can either self-assess yourself if you're somebody who is been experienced in vaccinating, or the centre that you are working with will go through those competencies and make sure that you have got all the necessary requirements. And there are some links that we've put on the website as well as on these slides. Just to say, I noticed there were quite a few comments in the chat when I was monitoring those. These slides are all on the COVID vaccine page already. Well, a slightly less updated version, to be fair, but the links are all there, and all the links are on the RCN pages. So can I have the next slide, please? So when you're delegating and accepting responsibility, there are various sort of decision-making processes that we've tried to break down. And as Heather has already spoken about, particularly with the COVID vaccine programme, it requires a range of different people working together. So the exact background and education will be different. Some people will come from primary care and community settings and be very experienced in vaccinating, have been doing it for a long, long time. And other people, it will be quite new to them. So all of the terminology, access to the Green Book, all of those sorts of things we recognise will be quite new to a lot of people. So one of the things is about knowing where to find information, and what the RCN pages and resources have done is to pull all of this together into one place so that hopefully it's easily accessible for people. But really the principles about good practice and supporting workforce are the same for the COVID vaccine as they are for any other redeployment. So it's the same principles, really. Can I have the next slide, please? So some of the things to think through: the legal authorization to administer a medicine. And I'm going to go through this in a bit more detail. So have you got that legal authorization? It could be a prescription or a PSD. Really, the two things are the same. It could be what we call a patient group direction. Written instructions might be used in occupational health settings, or this new direction, this new function, which is the national protocol. And the second thing is, have you got the required ability, required education requirements to go through and be able to vaccinate with confidence? Next slide, please. So the next thing to think about is, for everything and any clinical practice, is the delivery of this vaccine, and in this setting, in the best interest of the individual. So thinking back to what Heather was saying about certain groups of people, people with learning disability, people who've got particular needs, particular concerns, you may have to have opportunities to address those in different settings. And we need to be able to be a little bit flexible within the programme, given in mind that we want to vaccinate as many people as we can as quickly as possible, but have other options. And we know that with some of the what's being called the roving models with care homes, the teams are going in 2 or 3 times to make sure that they can vaccinate as many people as possible in the homes. And that's really helped in so many different ways to make sure that it's accessible. But also so that they've got opportunities to address any concerns that people have. And then thinking about people being satisfied that they've got the qualifications. Is all the training being gone through? Does it align with the training standards? And then if you are working with people who are not used to immunising, is there appropriate supervision? Can somebody call on somebody and get information as soon as they need it? And what I would really advise people to look at, there was already a question in the chat box, the COVID-19 and indemnity sections. So there are state-backed indemnity schemes for all COVID-related activity, but particularly in terms of vaccination, and the information is there on the website. Can I have the next slide, please? So then in terms of your accountability, everybody, as I said right at the beginning of this, my section, you're accountable for your own actions and your practice. We talked about some of the different roles that are needed. So the clinic supervisor or manager needs to be satisfied overall that everything is placed and that the people working in the hub have got the required skills. And then the manager is also accountable for the decision to delegate tasks, whether that's under the national protocol, but also any other work that's going on in the centre, and a record of their training assessment should be kept. So can I have the next slide? I've said of that being accountable in civil law. So we mentioned before, so vaccines are what we call prescription only medicines. So that means that they need authorization to supply and or administer from an appropriate registered practitioner. So that could be a non-medical prescriber, so nurse prescribers, physio prescribers, others could prescribe, and doctors and dentists as well are appropriate prescribers. If people are not prescribers, they would need to have some other form of authorization, whether that is a prescription and a patient-specific direction, which is essentially the same, or an alternative, and I'm going to go on to those. So can I have the next slide, please? So the alternatives under the legislation are patient group directions. Now, if people aren't used to using patient group directions, these are exemptions under the medicines legislation, but they are limited to be used by certain listed healthcare professionals. And I think Heather mentioned that nursing associates, although they are registered with the NMC, are not listed in the legislation to use a patient group direction. The challenge with a patient group direction is that you can't deviate from that direction. So you can't delegate within it. You can't sort of take one bit of the direction and do that and then ask somebody else to carry on and do the rest. If you sign up to the patient group direction, you have to complete everything within the direction yourself. Written instructions are specifically for occupational health schemes, and again, certain healthcare professionals can administer medicines under a written instruction. And then I'm going to go back to national protocols, but emergency medicines are also have exemptions in the medicines legislation. So, for example, you do not need a separate direction to give something like adrenaline if needed. If somebody does have an anaphylactic reaction in a vaccine hub, you can give it under the exemptions under the Medicines Act. So with a national protocol, the national protocol have come in specifically under the emergency legislation for the COVID programme. So I'm going to talk about that next. Can I go to the next slide, please? I'll talk about it in a minute. Sorry. So patient-specific direction. So just to reclassify what I just said, really. So it needs to have the name of the patient, the medicine. It needs to be clear about where, what the drug is and the frequency, and it needs to be signed by a prescriber. There's a useful web link on this from Nigel's Surgery, which is a CQC website, which talks about patient group and patient-specific directions. Next slide, please. And then the patient group direction, as I said, is a specific direction that certain registered healthcare professionals can use, defined to a particular group of patients, and people need to fit exactly within that group of patients. And the person who's working to the direction needs to follow through the whole direction. They can't delegate under it. And again, there's some useful links at the bottom of that slide that you will be able to access. Can I have the next slide, please? So written instructions, so that provides another legal framework for for certain occupational health schemes to be able to administer medicines. And this is allows a little bit more flexibility in an occupational health setting. And again, there is some really useful guidance from the specialist pharmacy service in relation to what a written instruction is and when you can use it. I don't think, to be fair, the written instructions are used very often with the COVID vaccine programme, but they are an option there if you need it. And then I'm going to just talk about the temporary changes to the legislation. So can I just move on to the next slide, please? So back in September, there was a consultation, and temporary changes to the human medicines regulation came in October. And those gave legislative changes for vaccine delivery, and including the authorization of vaccines, so allowing people to work under a different guidance and to work under a national protocol. Now, what the national protocol allows is that delegation of functions under the protocol. So as I said before, with a PGD, you can't delegate functions, but with the national protocol, you can. So each person who signs up to the national protocol accepts that responsibility and that accountability to work to the protocol, providing they've got the appropriate skills and competence and knowledge to do that. And the other thing that, from a nursing perspective, is that the NMC are supportive of the use of national protocols, and they have got information on their website as well to support that this is an appropriate and legal way to administer medicines. So can I move on to the next slide, please? So the national protocol is obviously aimed again to safe administration of medicines. Now, as Heather said at the beginning, the national protocol is essentially signed by the Secretary of State. It's put in place by the public health agencies, the NHS, so there is a slight variance in different countries, but essentially it is signed off by the Secretary of State, and it allows for everybody who is within the eligible population to have the vaccine, and allows for different people to take on different functions. And for those of you who are already working in the sector, you will know that the format is actually quite similar to a PGD, and it includes the characteristics and training of the people who are permitted to use the COVID vaccines, and the requirement for people to be authorised and supervised. It also specifies the record keeping requirements and all of those requirements for supervision, as we've said. So I just want to move on to this next slide. Now, just to say, next slide. So this is an NHS England, but to be fair, the process under it is similar for across the UK. And what this does is it describes those authorisation processes. So at the top, you've got under the protocols, all responsibility in vaccination are delegated directly to the individuals performing the task. So you've got your clinical supervisor, who is ultimately responsible for making sure that you've got the right numbers of skills, and they are the person who should be immediately available if people have got questions. So that's your overall sort of monitoring, if you like. Then you've got the clinical assessor, and as Heather said, when we put the summary, this person needs to be a registered healthcare professional. They're the person who assesses that the person in front of them is suitable for the vaccine, that they have consented, and essentially answer all the questions. Vaccine preparer is only really needed for the Pfizer vaccine. So the Pfizer vaccine needs to be pre-diluted before it's then drawn up and given to the individual. So it's been put in there as a separate function, really to enable large-scale delivery of vaccines, because if everybody who was vaccinating was also preparing those vaccines, you wouldn't be able to do it in the timely way. So this is essentially to make that whole process safe. With the AstraZeneca vaccine, it comes ready diluted in a vial with either 8 or 10 doses, and I know I'm going to get questions. Yes, you could maybe get 9 or even 11, and the national protocol allows you to take out the number of doses as long as you can get out a full dose of each of those. But that's just really to sort of clarify that you won't always need a vaccine preparer depending on what vaccine you're using. And then the vaccinator themselves. Now, the vaccinator themselves could be the same person as even the clinical assessor, or it could be somebody completely different. And under the protocol, that's perfectly reasonable. And that person needs to be trained in order to give the vaccine and needs to be able to respond immediately to questions, but will always be able to refer back to the clinical supervisor. So it could be a non-registered healthcare practitioner. And then your admin support, again, as Heather said, no reason why this couldn't also be a registered healthcare practitioner, but equally doesn't have to be non-registered healthcare workers, but make sure that there is clear records of what's been given, who it's been given to, and the whole process under the protocol. So I know there's a lot of information on that slide, and just to say that this slide is in the process of being updated. It's published by NHS England, and the final version of this updated version will be available hopefully early next week, but we've been allowed to use an early slide of it. Okay, next slide, please. So I'm just going to talk quickly about the priority groups. Now, the Joint Committee of Vaccination and Immunisation, so they are the advisory board made up of scientific experts from across the UK. There is a nurse who sits on JCVI and a whole range of other experts, epidemiologists, medical practitioners, vaccinologists, people who are experts in virology, and bacteriology, and all sorts of people. And you can look up on the website to see who is in the JCVI. So the JCVI have met weekly since the pandemic started, and they have come up with their priority groups for who should get the vaccine first, essentially. And as we know, the priority groups are based at the moment because both vaccines, the evidence is about preventing people from getting severe illness and disease and infection, disease from the infection. So when you look at the data, predominantly that is older people are getting really severe illness and dying. And people in care homes. So that is really where those priority lists have come from. So as you know, the first 4 priority groups, the aim is to vaccinate everybody in those four priority groups, or at least make sure they've been offered the vaccine by the middle of February. And all the indications are that we're on track to do that. And then after the middle of February, and some areas are already beginning to look at the other groups, but those up to from 50 upwards, and those in other risk groups. So it's a really ambitious programme in itself. And I think what's really challenging for a lot of people is that almost everybody wants to be in the top priority groups, because, you know, we've been living with this pandemic for a long time now, and people sort of see the vaccine programme as that light at the end of the tunnel. But I think one of the things that for all of us in this process of leading and supervising this is to try and manage the expectations as best we can. So it's just worth revising who those priority groups are. So the next slide, please, Gary. So I mentioned indemnity, and you've seen the links. So the human medicines regulations say that provided the vaccine is administered in accordance with the guidance, all staff who are employed in vaccination will be covered by their employer's indemnity scheme, and also the the state-backed clinical negligence scheme or COVID scheme, and the information about that is all on the website. So what's really important is whether you're working in a private provider or whether you're working in NHS, you are entitled to get the vaccine, but all the vaccines are being delivered through NHS services. So you need to have a contract of employment or an honorary contract if you're working in a voluntary capacity, to make sure that you are indemnified by the state-backed scheme. So next slide, please. So just a little bit on keeping up to date. So one of the things for all vaccination really is that things will change. So whenever I talk about vaccination, I suggest that people sign up to receive the Public Health England vaccine update, which actually goes out across the UK. And it's a really useful way of keeping up to date with information. And also to make sure that you look in the Green Book. Now, at the moment, because the programme is evolving, and Heather talked about some of the new vaccines that will be coming in, it's inevitable that the information will change. So I would urge everybody to make sure that they maybe save the link to the Green Book on their desktop. You don't have to be as sad as me and know the number of the chapter, but have it saved so that you can really access it easily. Save the RCN immunisation hub as you're on your desktop, because we will make sure that those pages are up to date. The public health immunisation hub as well, save that as your desktop so that you can access the guidance for healthcare practitioners, because all of this information, the Green Book, I'm not sure how many times it's actually been updated since the programme started 6 weeks ago, but it's been updated quite a few times, as has the guidance for healthcare practitioners. So probably not a good idea to get in, sort of be tempted to print it off. And just remember that all of the stuff that I've spoken about in terms of the national protocol and the PGDs, those are not the actual policies. Those are your legislative framework to allow delivery and allow administration. The actual policy around vaccination is really the Green Book. Okay, next slide, please. So this is a slide that we put in. Now, I think one of the things that we're sort of tested with a lot with this is all of the information that comes through social media, whether it's Twitter, whether it's Facebook, or just people posting information. Now, some of it's really good, but unfortunately, a lot of it isn't. And one of the challenges, I think, in all healthcare setting is that you can look up anything on the internet, can't you? And we all do it. We all Google it when we've been faced with a challenge. We'll think, well, I'll just quickly Google that. So this is something I found a few years ago in relation to vaccination, but it's a simple sort of like, is this a good thing to look at? And it's the smell test. So who's providing the information? That's the source, that's the S. Who's motivated? Why are they telling me this? Are they being paid to do this? Is it something else they're trying to sell? Is it an opinion that's sort of come from a way of life or something like that? So just be sort of a little bit, professionally curious about their motivation. Is it evidenced? And it's very, very tempting to sort of skip this bit, but is it referenced? Is it dated? And when was it last posted? That sort of thing. Does the headline actually meet what's in the actual article? Very often you'll see a really sort of snappy headline, and then when you read it, you think, well, that's not quite what the headline led me to believe. So just be a little bit curious about that as well. And the other thing is what's been left out, what's missing. So it's just a little sort of aid memoir that I know other colleagues have found quite useful in the past. So finding and trusting the evidence. Next slide, please. So this is just the further information, and obviously linking to the RCN COVID-19 vaccination page. Now the COVID-19 page, the RCN page actually has several functions within it now. You've got an education section, which is where the slides for this session will be, and the webinar link will be posted. You've also got a separate resource, which I've put underneath here, which is the immunisation services and large-scale delivery. So lots of hints and tips and things in there for people. And I've also put here a link to the NMC code. And for those of you who probably looking at the code, there is a separate section that the NMC have added around caring with confidence and the code in action, which really talks about using those professional judgments, but that also that the NMC would support healthcare professionals to do that. That's part of what the code allows you to do. So I think that's towards the end. So I've just got one more slide, which is obviously to carry on vaccinating. And Heather quite rightly said, you know, there's some amazing stories and some amazing bits of work going on. And this is a link to the RCN Direct if you want contact, if you want support, if you want help. So I think that's the end of the presentation. I know that there are lots of questions in the Q&A.
I thought I'd just summarise a few for you, Helen, because you've been doing some of the talking. V. Leafort says, thanks, RCN. Helen, it's been a while since she saw you. Lovely to see you and get this update. And then we've had a couple of comments. One was around medical students and how useful it's been having medical students in the vaccination clinics, and another one around how valuable it's been having healthcare support workers in the vaccination clinics. So that's really good. I've tried to answer some of the questions as I saw you did as well while I was talking, but there's a couple of them I thought I'd leave for us to go through maybe at the end. So let me just have a look and see the first one I can see. So what happens if you are returning to practice and would like to support? What to do? What do you do?
Okay, so it's a really good question, and I think, you know, as the programme goes on, those sorts of offers to help will become more and more important, because I think at the moment there's a lot of redeployment of staff within existing services to get these systems up and running, but to make them sustainable and to carry them on, there will be an absolute need for other people to come through. So certainly for England, it's through NHS professionals. I know that there is a lot of angst in the system because it sometimes takes a long time to get through that process. But I think, you know, the main steer is to stick with it. But also, I know some people contacting their local primary care networks to offer that support. But the links to the education, the training requirements are also on our web pages. And I think for people who are registered healthcare professionals, there is certainly an allowance now that you can self-certificate, you can self-sign off that you've done the requirements. But if you're not experienced to immunising, I would go back to the national minimum standards. There's an e-learning for health module, and particularly the modules on consent, the modules on the legal principles, and the module on vaccine administration, because I think that will help. But the COVID vaccine programme is really quite comprehensive, and it goes through the steps. So have a look on e-learning for health. If you haven't got an NHS email, you can register separately to use it. It does take a little bit of time, but you can access it.
I think just to reinforce that, actually it might be worth going to more local providers as well. Particularly if you're an experienced immuniser, definitely they'll be looking for you. So yeah, definitely go to those people. That's the way we did it. Okay, so does a GP have to be on site when a registered nurse vaccinator is administering COVID vaccinations in a GP surgery?
No. I mean, I think the key principle there is that you need to have people who are trained in basic life support and anaphylaxis, because what you need to be able to do is to call for help promptly if needed. So that needs to be somebody who goes and calls for the ambulance, calls 999, and that essentially is the principle. And with all credit and respect to my GP colleagues, it doesn't need to be a GP who does that, as long as you've got the experience and that are happy to do it. So we've always said as a college that you don't have to have a medical practitioner on site to do that.
I think that's a principle with any immunisation programme, isn't it? Because they are queries we get. There is no requirement for a GP to be on site when you're vaccinating. That's great. I don't know if this one's a typo. IPGD does not apply to COVID vaccination. So I'm assuming that they're asking if there's a PGD for COVID vaccine, and there is a PGD been developed for both of the vaccinations that are available currently, and they're on the website, aren't they?
They are. I suppose the question might be is why would you use a PGD? I think the thing is, if you are working just with registered healthcare professionals, they would need to do the whole process. I have to say, where I am helping in a hospital hub, we're using a PGD, and so I mix the vaccine and then take it over and draw it up and give it to the individuals, and that's the way it works very well. But if you're working in a mass centre or a primary care hub where you're having different people doing it, you wouldn't be able to use a PGD. You can't, legally you can't. You'd need to use the national protocol.
Because you can't delegate in a PGD.
Because you can't delegate, yeah.
I've answered one about patient-specific directions. So yes, nurse and associates, healthcare assistants, unregistered staff who've been trained appropriately can work from a patient-specific direction, but they can also work within the national protocol as well.
Yes, they can work to bits of the national protocol, particularly the vaccinator roles and the administrator roles. Yeah.
Should you delay COVID vaccination if the patient just had their flu vaccination within the last 7 days?
That's an interesting one. So the Green Book says that ideally you need to have a 7-day gap between the two. And really the reason for that is that there hasn't been any testing on giving vaccines in association with the COVID vaccines. But they're inactivated vaccines, they're not live vaccines. So there wouldn't be any expected interference between one vaccine and the other. So I'm using normal principles of vaccine administration. You wouldn't need to worry. The rationale for leaving 7 days is so that you wouldn't associate side effects one with the other, so you'd be able to monitor. But what the guidance in the Green Book says is if somebody comes and they have just had it and you're worried that they won't come back or it's going to be difficult for them to come back, then you could give them, as long as you explain that there isn't any information about, giving it so close together. But under normal principles with most other non-live vaccines, you could give them together the same day, any gap apart. So that's the principle in the Green Book.
Yeah, so if you've got someone, for example, I don't know, someone who you just know is it's not likely to come back again, then you can use the exception to vaccinate them, can't you? Mm-hmm. Okay, this may be daft, but is it advisable to have the vaccine yourself before administering? I'm still on the register, but not in clinical practice, so not frontline.
So the guidance around healthcare staff, and there was a question earlier I saw about people who work for private providers. It's all health and social care staff, and that includes vaccinators. So I know there's been different sort of approaches in vaccine hubs up and down the country, but if you're giving vaccines, then you are then working in a frontline capacity. So yeah, my steer would be that you should have it. Obviously, it depends on, you know, how quickly you can access it, etc. But absolutely, you should be able to have it. Remember, the vaccine is going to take 10 to 14 days to build up any sort of antibodies. So whether you have it, you know, before you vaccinate, you know, it's going to take a little while to build up any antibodies. And remember, no vaccine is 100% effective. So at the moment, we're being very cautious in saying that this doesn't give you open access to stop, you know, social distancing and self-isolating if you need to, and all of those other requirements.
Yay. No wild parties, I've been saying to the patients. You still have to stick to the rules, I'm afraid, for the foreseeable future. Okay, so what are the main challenges in a vaccination programme? For me, some of the main challenges were initially was the amount of people coming through the door. So getting the flow of patients through a building was really key. You know, we ended up with quite a lot of people in there. Then there became the risk of whether we were providing social distancing for those patients. So I think one of the things for me, and I'm sure you have something else, Helen, but one of the main things for me is making sure that the admin process and that the organisation is there and that there's enough people to be doing each of the different steps. So I don't think you can never have enough people directing the traffic and helping people get to where they need to be. That would be my advice.
Yeah, I would agree, and I think the thing is that, and we've discussed this a lot, you know, in the sort of like national groups, and there's only so much that you can do at a national level. You need to have, you know, local, you know, the logistics of where you're working. So, you know, use those national protocols, but then plan around them and go with the principles of best practice for immunisation, but also for general patient care. So, you know, as long as you can, you know, to abide by those principles of safe practice and making sure that people are getting access to the vaccine, I think, you know, just be confident to use those professional decision-making skills and adapt according to the clinic environment, the logistics of where you are, and the patient group. And think, you know, as we go through the priority groups, some of those logistics will change as well.
Yeah, absolutely. So someone's asked if they can share the visual guide on the national protocol. Can it be shared?
Can you wait until next Monday? Only because that particular version hasn't been finally signed off. But what I would say is, if you go onto the NHS England legal principles for vaccination, there is a very similar version of that on the website. It hasn't changed a huge amount. It's just that there are some tweaks in it.
Just having a bit of a coughing fit here. How would you be able to ensure that the second vaccine would be the same vaccine as the first one?
Okay, so again, I mean, at the moment, we haven't been given any indication that the supply issues will be a problem for that. And as you know, the guidance is absolutely that we would want to try and make sure, wherever possible, that the same dose of the same brand of vaccine is used for the second dose. But because certainly the two vaccines that we're using are based on the S spike of the coronavirus, the Green Book guidance is again a bit like for the other question. If you're really worried that somebody isn't going to be able to come back, or you need to be able to give it, then it would be appropriate to give the locally available vaccine. But wherever possible, we are recommending at the moment that it is the same brand. But again, that's based on the evidence that we've got. And, you know, there are trials going on to look at the sort of interchangeability between the different vaccines. So again, you know, that guidance will adapt, and it's about keeping up to date with the Green Book. I hope that answers the question.
Can you see? Oh, there's low uptake in the BAME population. How is the RCN supporting this?
So I think, you know, it's a really good question, and I think it's all minority groups as well. there needs to be specific support given and questions, whether it's myth busting or whether it's sort of access at particular times. So it's really heartening to see some of the vaccine hubs in mosques as well as in churches, because I think that gives a sense that, you know, from a community point of view, I know there's a lot of work going on at community level to sort of try and address those issues. From an RCN perspective, we're just in the process of putting some more information on the website with some, you know, Q&As. There's some lovely Q&As from the British Islamic Medical Association. If anybody wants to have a look at them, the link is on the RCN website already, and that might help, because, you know, you know, poor uptake in the BAME community, that's sort of a whole range of different views and things. So you need to be able to talk to those individuals, what are their concerns, and then hopefully be able to address them. The worst thing I think you can do is sort of almost preempt what people are worried about and try and address them. You need to have that conversation.
Can occupational health use the national protocol, or only a written instruction or standing order?
No, occupational health can use the written the national protocol. There's no reason why not, as long as all the process is in place. It's just that there is that added option to use the written instruction if it suits the service better. And some occupational health providers are outside of NHS, so it might be a better process. But for the national protocol, that wouldn't apply, as long as you're feeding that information through the national immunisation system for NHS.
There's a few questions on patients who are on warfarin or on a cocktail of anticoagulant drugs and their INR. My understanding is that these patients, you should just establish that they're well controlled and advise them of the risks after vaccination, and apply a little bit more pressure. So hold on to the swab when you've done the vaccination, just to try and prevent them from getting a bruise, but warn them about whether that they might get a bruise, and also make sure that they are aware that if it continues, then they need to come back and get some advice. Would you add to that, Helen?
No, I think that's absolutely right. It's one of those questions that's been rumbling around. Lots of information come over, you know, from the flu programme as well as other vaccine programmes about people who are on anticoagulants. But I think that advice is absolutely right. It's you know, if they're well controlled, then it shouldn't be a problem. But even so, it's that they need to have the vaccine. So, you know, put a bit more pressure when you take the needle out and hold the swab in place.
Yeah, just to make sure and check they're not bleeding.
Yeah.
Okay. If you're working from a PGD or the national protocol, but have, oh no, that we've already answered that one, sorry. Someone suggested a webinar on COVID secure workplaces, so maybe we'll talk to our infection control colleague about that. See if Rose is interested, but thank you for your comment. In a centre with mixed band 3, 4 and 5 staff, would it be better to use the national protocol rather than a PGD, or would you use both depending on staff grade?
I think for ease, you would use the national protocol, wouldn't you? Because you know, essentially they're allowing you to do the same thing, and there's no reason within the national protocol that the same person couldn't do all functions. So it's just a question of you know, the logistics and the practicality. You know, your band 5 could use a PGD, but they would have to follow throughout, and you might have one day where that's appropriate to do, and other times where you want to separate the tasks out. So, you know, there's no reason under the national protocol why you can't have the same person doing all functions. So I don't know. I don't think there's an absolute answer to this, but it would seem sensible to me that you use the national protocol for ease, really.
I think not using the national protocol, when you're talking about a big centre like that, you might end up, if everybody was using a PGD, you might end up with too many vaccines available. So especially coming towards the end of the day, if you've got 5 or 6 vaccinators who've then got a vial full of vaccinations, you then run the risk of not using them, don't you? Because once it's mixed, they have a certain, it's only
that's a really good point, actually, because I think, you know, when you're working in any centre, it's about keeping an eye out, so how many people are coming in, so because we don't want to waste any of this vaccine. It's really, I think the national leaders, they refer to it as gold. I think that's, if you think about it in that way, it's really precious.
Yeah. And I know as we were coming towards the end of the day where I've been working, they've been making sure that we don't, draw or don't mix too much vaccination, so that even with the AstraZeneca, you have a certain length of time once you've taken the seal off and drawn the first dose. So actually, it's just making sure that we're optimizing the use of the vaccines and not throwing stuff away at the end of the day. There's a question here. If you're working from the national protocol and administering on the 11th dose, do we need a PSD as it's not covered by the PGD?
Well, I think it is, actually. I think the PGD has been amended to say that, I can't remember the exact wording, but it sort of says, the vials are intended for Pfizer for 5 doses, but an additional, if you're using dose-sparing needles, an additional dose might be possible. And I think it's exactly the same wording for the AstraZeneca in the PGD. So I think this is probably a question of making sure that you've got the most up-to-date version of the PGD in front of you and you've signed up to that.
There's a question here about resheathing of needles. So if you've got someone who's doing the drawing up and someone vaccinating, if you're unable to change or resheath needles. Now I've seen in the centres that I'm in that they have like a resheathing device so that you can resheath the needle without actually handling the bit that you're likely to stab yourself with.
So yeah, I think the issue here is that under the health and safety executive legislation, there is very clear guidance that you shouldn't resheath. But if that is the way that the service is being run, there would be a risk for passing unsheathed needles. So what the health and safety executive, what the legislation says is that there needs to be a thorough risk assessment, and the HSE would want to see that risk assessment if you are resheathing. And as Heather said, there are devices that you can use to help that process. But I think it needs to have some sort of local scrutiny and local risk assessment to make that possible. Because, actually, you can mix the vaccine and then give it to the vaccinator to draw up the dose and administer. That would be perfectly reasonable. And, a lot of people have found that actually is just as time saving as not doing it that way. So it's about your local risk assessment. As I said, there's no one way, but you need to sort of think about the legislation.
And also the fact that the vaccine shouldn't be stored in the syringe for any length of time as well. Yeah. That's not the precedent. Are there any religious considerations in relation to the ingredients, for example?
Well, there are no fecal material in the vaccines. There's no animal material in the vaccines. None of the vaccines have porcine in them. So essentially, no. The AstraZeneca vaccine, the cell line used, historic fecal line, and there's some guidance on the PHE website about that, but there's nothing in the actual vaccine. So, essentially, no, there isn't anything, but all the ingredients of the vaccines are listed, and we've put that information on our website.
If someone's tested positive, has test positive of antibodies, long immunity from having had COVID-19, is it advisable not to accept the vaccine or advisable to take the vaccine in view of different strains?
I mean, the guidance is absolutely to have the vaccine as long as you're over your illness. I mean, if you've already got circulating antibodies, in theory, what the vaccine will do is boost those. So there's no reason, there's certainly no risk been identified with long COVID. And again, we're putting some information on the website about that. I've just had an email that the website has been updated while we've been talking, Heather.
Good. Is there any national guidance around obtaining the vaccine for those who are anticipated to be to have a long stay in an acute hospital? The JCVI haven't come out with any guidance on that, have they?
Not as far as I know. I mean, there has been some talk about, you know, pre-admission, but I did have a look. I haven't seen anything clear about that. No. Remember, the vaccine at the moment is about stopping severe disease, not about stopping necessarily people contracting the infection or of transmitting it. So, you know, that might change.
Yeah, I mean, if they're in a high risk group, they might vaccinate them,
Yes,
mightn't they? Or if they're elderly. Yeah. So what is the guidance on administering for someone who has tested positive in recent weeks? In my setting, staff who've tested positive 14 days prior were given the AZ, but patients who recently tested positive weren't.
Yeah, I think the guidance is specific that you should have a 2-week gap from and be asymptomatic, because what you don't want to do is risk associating COVID symptoms with symptoms of the vaccine. So if you've just had a recent test and you haven't had the 10 days, then you need to wait and make sure that you're not symptomatic.
And then there's what clinical advice would you give for people who have a multiple comorbidities, which vaccine is best? And we wouldn't be, there is no guidance, is there? Both vaccines are recommended for people with comorbidities. Yeah,
absolutely. I mean, you know, that sort of data isn't available. So both vaccines are equally recommended for any group. I mean, again, who knows whether, you know, as more vaccines come online and the data and on the efficacy and the different sort of nuances become available, whether that will change. But at the moment, no.
And I think there's one final one, which I know we'll know the answer to. PPE. Do we need to don and doff a plastic apron for each patient?
So, I think that's an interesting one. So, in theory, yes, they're single use, so aprons. But you know, for a lot of people, if you're wearing the apron to sort of protect your clothes in a vaccine centre, a sessional use apron would possibly be appropriate. I mean, as you know, the guidance says that you don't need to use gloves and aprons, but from an apron perspective, it's about what you're wearing. You know, and a lot of people come in on a voluntary basis might have scrub tops or something, or they may just be using a plastic apron to cover their own clothes, and so sessional use might be appropriate in that situation.
So someone higher up mentioned that you needed to be, as a qualified nurse, you need to register with the NMC for inclusion on the NMC COVID register. If you're registered with the NMC, you don't need to be on a specific register to vaccinate. What the confusion might be there is that there is an emergency register, isn't there, for people who have had, who like third year students or people who've left the register and are coming back for a short time. There is an emergency register, but that as long as you're registered with the NMC, there isn't a specific COVID register.
Yeah, no.
Okay, I think that's probably it. And with 2 minutes to go, have you got any final words, Helen?
No, I just thank you all for joining us. I think we've had a record number of people joining the webinar, and we will look at the questions and see whether we need to update the FAQs at all. But just to say, as I say, I've had an email while we've been talking that the FAQs have been further updated, and we are updating them all the time. So do keep a look on those as well. But thank you for joining us, really.
And also don't forget to look at the website, because there's a wealth of resources, including this presentation, that's available to you, including the FAQs. There's links to the training that you need to do, and hopefully it's a really useful resource to you. So your feedback on that would be really appreciated. I just want to say thank you to everyone for attending. Thank you for some of the lovely comments. We really hope that this has been useful to you, and that you've gone away assured in what you're doing, or have learnt something new during this presentation. So thank you very much.
Yes, thank you.